The topic is about perfusion imaging, and we have heard in previous talks during the week that neuroradiology is a very exciting area. We do see a lot of functional imaging technique that needs, of course, a proper acquisition as well as very important good post-processing. And this how-to session over lunchtime is a session where we address that both in CT and MRI. And I'm very happy that we have two very distinguished speakers, Professor Adam Davis from New York, who will give us insights on brain perfusion in the theory and practical applications. And then Professor Kambis Nael from University of Arizona, who will then address another important point, and that's the proper dealing with our contrast media resources that we have available. The how-to session is sponsored by Olea Medical, has to be mentioned, and we will see what kind of new developments we do have. But just let me introduce that session just briefly, because I think it's very important to know that a lot of the clinical questions we as neuroradiologists are faced in the clinical pathway of the patients or the clinical journey of the patients, from diagnosis over therapy planning as well as treatment follow-up. We are faced with a lot of questions which we cannot answer with standard imaging techniques, and therefore we do need, and we have introduced over the last couple of years, more and more so-called functional imaging techniques that need proper acquisition as well as a proper post-processing. And there have been tremendous work done. Just a few highlights over the last couple of years. There have been some general recommendation papers out. What are the most clinical and technical questions on perfusion? This is one that came out just last year. And the protocol recommendations have also been updated, both in tumor imaging, MS, stroke imaging. And very important to know, and one of the speakers will address that very detailed, is that we are now not using only one time a contrast media injection. In many of our clinical protocols, we do inject contrast media several times. And on the other side, in respect of costs and safety issues, we have to stay with a certain dose, and therefore we need to introduce techniques that allow us also to scan at a lower dose. So, and this is a slide I got from Alex Rovira. He updated a little bit that initial outline, and you see here that both in the or in all steps of the pathway, before treatment, in the therapeutic decision process, as well as after therapy, we now use on a routine basis those functional imaging techniques. And beside the technical questions, I hope that we can also see what can be done in the clinical environment, how can we apply those techniques into the clinical environment, mainly in stroke and tumors will be focused on today. And I'm looking very much forward to the two presentations, and I would like to invite Adam to come to the stage and start with his presentation. Thank you very much.
Marco, thank you very much. I'd like to thank, first of all, I'd like to thank everybody for coming to this session. I appreciate your being here to listen to us speak. I'd also like to take this opportunity to thank Olea Medical for sponsoring this session. We're going to discuss the theory and the clinical practice of brain perfusion imaging within the next 30 minutes. And I'd like to start the lecture back in 2005. And an article entitled Accuracy of Dynamic Perfusion CT with Deconvolution in Detecting Acute Hemispheric Stroke. And back in 2005, this article, authored by Wintermark et al., concluded that dynamic perfusion CT maps are more accurate than non-enhanced CT in detecting hemispheric strokes. Despite limited spatial coverage, perfusion CT is highly reliable to assess the extent of stroke. And now I want to fast forward to just 6 months ago, November 2013, and in a joint paper issued by this body, the ASNR, as well as the American College of Radiology and the Neurointerventional Society, in this joint paper, they concluded that although perfusion imaging has been incorporated into acute stroke imaging algorithms at some institutions, its clinical utility has not been proved. And then they went on to say, perfusion CT is another method used to assess ischemic core and penumbra. Similar to perfusion MR, there is no clear consensus on the optimal perfusion parameter that is most predictive of tissue viability and outcome. So the question is, what happened in 8 years? Why did we go from this promise of perfusion into a state where perfusion CT and perfusion MR is called into question for stroke evaluation? And I think in order to do that, we need to look at the fundamentals. We need to understand the foundation of perfusion imaging and then build it back up again to understand why we are in this situation. So perfusion imaging is based on two assumptions, clinical perfusion. And that is the first, surrogate markers like contrast, iodinated contrast and gadolinium imitate circulation. And that is a fairly safe assumption to make. The second assumption, that imaging data is converted into meaningful physiologic correlates by models and algorithms processed on dedicated software, is not a safe assumption to make. And in order to understand that, we need to look at the 4 problems that led us to this current situation. The first is that the models that we use to interpret our perfusion data are inappropriate. The second is that the acquisition protocols in MR and CT are inconsistent between scanners, between doctors, between institutions. The post-processing techniques that we use are inaccurate. And lastly, there is confusion and misinterpretation regarding what the relevant brain indices are for determining infarction and penumbra in the academic and in the clinical practice. So in the next 30 minutes, we're going to review the basics of brain perfusion imaging, what are the difficulties, and what are the possible solutions to this problem. We're going to focus on cerebral ischemia because that's what I do for a living, but this theory is still applicable to brain tumors and all other applications of perfusion imaging. And what I'm hoping, not to spoil the lecture, but what I'm hoping is by the end of this lecture, you come to the feeling that brain perfusion imaging is a robust, reproducible, informative, and necessary technique for neuroimaging. So let's start at the bottom. The measurable data that we have when we do perfusion imaging is the signal intensity on MR or the attenuation in CT within the voxel as a function of time. When we measure it in the blood vessels, it gives us the arterial input function, and when we measure it in the parenchyma, it gives us the tissue concentration. We need to take this signal intensity and we need to convert it into a concentration of contrast. And we do this by an equation, of course. It's the concentration of contrast is the signal at a given time divided by the baseline at a given time to give us a ratio, and we multiply that by the natural log of K. So we're one slide into this lecture, and already we've encountered a problem. The natural log of K is not known. This is a constant, and it is dependent upon angioarchitecture and the acquisition parameters that we use during our perfusion imaging. Since K is estimated, we cannot accurately quantify the tissue concentration in a given voxel. And that is the reason that we tend to use relative values in perfusion imaging. So there are 5 commonly used indices, which you are all familiar with: time to peak, cerebral blood volume, cerebral blood flow, mean transit time, and Tmax. And we will go through each of these indices and how we arrive at them. So the first is time to peak. And time to peak is the only one that doesn't require complex mathematics. It's easily derived from the concentration curve, and we basically measure the time from the beginning of the acquisition until the time of the maximum peak within the voxel. It's in seconds, and it's a simple indice to obtain, and it's reproducible. The problem is that this is a time-sensitive parameter. Time to peak, a longer time to peak, was commonly interpreted as decreased blood flow. But that's not true. Just because blood flow to tissue is delayed does not mean that it is inadequate. It just takes longer time to get there. Perfectly adequate collateral flow in the brain has a longer time to peak. So we moved on to cerebral blood volume, which seemed to be the natural next indice that we could utilize. It requires the least complicated mathematics. It's the area under the first pass curve. It's simply the integration of the curve, the area under the curve. and it is the most reproducible indice across all of the software vendors. So easy. Seems like this should be the perfect indice, but unfortunately, there are problems. Let's take a closer look at the concentration curves and cerebral blood volume. The first is that there is no perfect concentration curve. Recirculation corrupts the curve. First, the contrast perfect. First, the contrast moves through. We see the peak. It starts to decrease within the vessel, and it never returns to baseline because by the end of the curve, recirculation is increasing the signal intensity once again. So to compensate for this, we do a best fit for that curve. So right off the bat, we are already estimating the value that we're looking for, and this introduces bias into our equations. Secondly, there is no correct concentration curve within the brain. Differences in bolus arrival time are normal due to normal physiology. In this graph, we see that in the artery, we have a very fast uptake curve. It peaks rapidly and comes down, just what you'd expect from the artery. But the concentration curve in the tissue is a little bit delayed, and we can see much lower, and it's more spread out. And within the white matter, it's even lower down and more spread out. These are normal concentration curves in the brain. Unfortunately, this creates problems when we determine our CBV indices. Typical perfusion protocols truncate the end of the CBV curve. And it does that because we look at the artery, we look at the concentration curve, and then we use that concentration curve in the artery to determine the end of circulation. The problem is, in the tissue, circulation is still going on. So what we do is cut off the end of the tissue curve whenever we look at the AIF. So slow flow or delayed flow typically has an artificially smaller area under the curve. So why is that important to us? The reason is because of how we interpret CBV. We commonly believe that as cerebral blood flow falls off, and the capacity of vasodilatation to compensate for that becomes inadequate, that cerebral blood volume falls off. And what we have come to believe is that decreased cerebral blood volume is the signature for irreversible infarction. That is the core. The problem is that we routinely underestimate CBV. So consequently, we overestimate the area of infarct. So the parameter that we have traditionally used in neuroradiology for over a decade to determine what infarct is inaccurate. So I am hardly the first person to say this. This is an article by Campbell et al. In Stroke 2011. And in this article, they conclude, in contrast to previous reports, CBF corresponded with the acute diffusion weighted imaging lesion better than CBV. Although no single threshold is good, CBF has a better correlation with the diffusion than CBV. And this relates to the low signal-to-noise ratio within the studies and emphasizes the need for optimized acquisition and post-processing. In a similar study in radiology, in the Gray Journal in 2013, Bavard et al. Found a similar result, and they said that a double core threshold with a delay time of more than 2 seconds and cerebral blood flow less than 40% provided the most accurate definition of the infarct core. And this was so against the grain for our society that they felt the need to say in their article, this is a departure from the previously widely accepted view that CBV is the best used to define infarct core. Of course, very low CBV is indicative of infarction. When you have no flow, you certainly have no viability. But no single threshold accurately defined the infarct core compared with cerebral blood flow. So that takes us to cerebral blood flow, which may be the natural indice for looking at areas of ischemia in the brain. Excuse me. Cerebral blood flow can be easily determined by the slope of the initial curve of the upslope of the concentration curve. A rapid upslope, more rapid cerebral blood flow. So ideally, you want a rapid, well-defined, compact contrast bolus to pass through the vasculature. This simple CBF measurement, unfortunately, has problems. All of the following issues delay or reshape the curve. The type of contrast you use, the injection rate, the injection volume, intravenous mixing, cardiac output, angio architecture. So CBF is a technique-dependent indice. So this is a slide that I tend to use with my fellows for teaching them CTA, but it illustrates the point. This is in an animal model developed by Rendon Nelson, and we're looking at two different injection rates in this model. And the first is an 8 cc per second, and the second is a 4 cc per second. So we can see in the exact same cerebral blood flow in these models, if you inject quickly, you would have a steep curve and interpret this as rapid as increased cerebral blood flow, and with the other curve, a decreased cerebral blood flow or lesser cerebral blood flow. The viscosity of the contrast reshapes the curve. Low viscosity contrast has a steep curve because you can inject it more rapidly, and higher viscosity contrast has a less steep curve. So that would be interpreted as decreased cerebral blood flow. Again, it's the same cerebral blood flow. It's just dependent upon the technique that you use. So how do we accurately determine the initial slope of the curve for CBF? And the answer is we do that by entirely abandoning this technique. So that brings us to the residue function. Signal intensity measured in a voxel is not an accurate representation of CBF. The upslope of the curve is due to the progressive accumulation of contrast in the blood pool during the injection. That doesn't represent flow, that represents injection. Theoretically, the ideal way to determine blood flow would be if you could just instantaneously take contrast, put it in the voxel, and then watch it disperse. And then you would know you're not dependent on accumulating contrast. You're just delivering it into the voxel and watching it flow out. That's exactly what our mathematical algorithms do when we use deconvolution methods. So to understand that, we need to move into deconvolution and understand what this phrase is. Okay, deconvolution algorithms. You hear this phrase all the time. Basically, these are complex mathematical equations that convert concentration time curves in the tissues and the arteries into meaningful clinical parameters. They use two functions to solve for a third, and you receive a modified version of one of the first functions. The result is the area of overlap between the two functions as you take one function and translate it or move it through the second function. So you can consider this one of the tissue concentration curve, and you can consider this second curve coming in to be the arterial input function. This is just an example. These aren't true curves. What deconvolution and convolution mathematics do is they take one curve, translate it through the other. And we can see here's the area underneath the two curves as you move one through the other. What we are now forming is a third function that describes the area between those two curves. And we can see as the volume increases, the curve increases, it reaches a maximum, and then it starts to decrease, and the function decreases. That's what convolution mathematics are. And I thank Wiki Commons because there is nothing that you cannot get on the internet. So, cerebral blood flow, Tmax, and the residue function. We measure the signal intensity in the arteries, and that gives us the AIF, the arterial input function. We measure the contrast signal in the tissue, and that gives us the tissue concentration curve. The residue function is the deconvolution of the AIF and the tissue concentration. It is the instantaneous signal of contrast, otherwise known as the impulse, and the washout curve of that voxel. The residue function gives us the CBF, Tmax, and the mean transit time. So, this is what the residue function looks like. It's a sharp upslope curve with a fairly rapid downslope. The height of that curve is the cerebral blood flow, and that makes sense because if you deliver a lot of contrast into a voxel, you'll have a large signal. If you deliver a small amount of contrast into the vessel, you'll have a smaller signal. So the height of that impulse represents the cerebral blood flow. when that happens is called the Tmax. The downslope of the curve is the washout of the tissue, and the average of that, the mean weighted average, is the mean transit time. The interesting thing about convolution mathematics is that it normalizes the two curves. So up top we have an ideal arterial input function. It's perfect. It just instantaneously occurs. And the tissue concentration is perfect. The residue function looks like that. But if we take real tissue, where we can see here's the arterial input function, it's a little bit more gradual. And here on the other side we see the tissue concentration a little more gradual. The residue function still looks the same. We normalize the two curves, and that obviates our accumulation flow determination problem. So let's take a look at the time to residue function. Tmax is not a true physiologic value. It's a theoretical construct. It reflects the bolus arrival time. And people tend to think of Tmax the same way they think of mean transit time. Delayed Tmax has a delayed antegrade or a collateral circulation. And Tmax is easier to interpret than CBF since it's in seconds and there's no difference between gray and white matter. So in the literature, increasing Tmax correlates with the final infarct volume, and a more moderate delayed Tmax tends to define penumbra, that tissue that is ischemic but will not go on to infarction. And there is tremendous variability in the literature as to what actually defines penumbra. Anywhere from 4 to 6 seconds in most literature, 5.5 in one article. The issue is that we use Tmax in all of our clinical trials, in diffuse 1 and 2, in epithet, in MR rescue. And all of these trials used different indices of Tmax to determine what the infarct core is and what the penumbra is. There is no consensus in our clinical trials as to what the correct indice is for determining infarct. Tmax is strongly influenced by signal-to-noise ratio. It is inherently an inaccurate indice. And furthermore, Tmax is not an absolute indication of what will and what will not infarct. The last indice is mean transit time. And mean transit time is the average time the blood remains in the volume of tissue. We can derive it directly from the concentration curves, but we know we don't want to do that since that's degraded by injection kinetics. We can derive it from the CBF and the CBV, but we don't want to do that because we know that's degraded by injection kinetics. So what we do is we use the residue function, and we take the mean weighted average of the downslope of that curve, and that gives us the average amount of time that the contrast remains in the tissue before it's washed out. So increased mean transit time reflects reduced cerebral blood flow. Its relative mean transit time of greater than 145 has been percent of the contralateral hemisphere, has been interpreted as core infarct. And an increased mean transit time identifies tissue at risk for infarct or penumbra. The advantage of mean transit time: it's sensitive and conspicuous, eliminates gray and white matter differences because it's in seconds, and it is a time-insensitive deconvolution. There's no significant artifact with the delayed concentration curve. The disadvantage is that, again, delayed flow through tissue doesn't necessarily mean that the flow is inadequate. Tmax doesn't necessarily indicate risk of infarction. Furthermore, mean transit time is degraded by the same factors that influence residue function. So, that's it. We're done. Those are the indices that we have to play with. There's nothing left. So now let's take where we are and see how well we're doing. So this is an article by Sasaki and Kudo, and in this article, they looked at 5 major manufacturers, all of whom have booths here at the ASNR, and they looked at their software, and they took infarct cases, and they determined what was the relative cerebral blood flow, mean transit time, and CBV compared with the contralateral hemisphere that determined what the ultimate infarct was shown to be. And what they found was, depending upon what software you used, your results were anywhere. There was no correlation between these software manufacturers. If you believed that a cerebral blood flow of less than 0.4 indicates infarction, well, only 2 of these manufacturers would have given you an infarct, while 5 would not have indicated infarct. The same is true for mean transit time and to some degree for cerebral blood volume. Many people have come to this conclusion. This is an article out of Mass General, and what they concluded was, using 3 different software manufacturers, the absolute optimal CBF thresholds were different, as were the relative thresholds, 0.84, 0.72, and 0.68, depending upon what software you used. Same patient, different software, gives you a different result. So, what is the consequence of this algorithm, model, and post-processing inaccuracy? Take you back to March of 2012, Gilberto Gonzalez states, there is no advantage to CT perfusion in the evaluation of stroke. It is unreliable for determining infarct core. He followed this up with an article in the JNIS journal, and in this he says, the contrast-noise ratio of diffusion imaging for determining infarct is more than 8, but by MR perfusion, the CBF value, CNR, is less than 1. This is a case example from my institution. This is somebody with a left MCA occlusion who's going to go on to have a left hemispheric infarct. And we can see, and this is using the American Board of Radiology algorithms for determining contrast to noise ratio. Within the basal ganglia, the infarcted side on the left compared with the normal side on the right, we have a signal to noise ratio down here at the bottom of 1. Ischemic tissue versus normal tissue versus noise. Up in the centrum semiovale, in the white matter that is ultimately going to infarct, we have a signal to noise ratio of 0.5. Low signal to noise ratio influences the integrity of perfusion measurements. So what is the consequence of this? And this is the consequence. Let's go to the MR Rescue trial, published New England Journal of Medicine, February 2013. And in this trial, they basically said, we're going to take people who have large vessel occlusions, and we're going to see if we can use neuroimaging, perfusion versus core, penumbra versus core, to look for a favorable pattern of people who we can salvage by opening up their vessels. So we're going to then do endovascular treatment, and we're going to pull the clot out of their vessels. And at the end of this very well-constructed trial, they concluded a favorable penumbral pattern on neuroimaging did not identify patients who would differentially benefit from endovascular therapy for acute ischemic stroke, nor was embolectomy shown to be superior to standard care. Surprising things happen in medicine all the time. I'm very surprised that if you have somebody with a large vessel infarct or a large vessel occlusion, and you actually remove the clot and reestablish flow, that nobody tends to benefit from that. Don't you find that surprising? So is that true? When we do an embolectomy and we reestablish perfusion in someone's head, does it make a difference? Let's take a closer look. This is from the 120-page protocol edition for the MR Rescue study. It's on the New England Journal site. Okay, it's great reading. I suggest you all go through it. But if you look carefully in that 120-page document, you can find the actual values they use to determine infarct core and penumbra. And they use multi-parametric functions to determine that. For MR, they used the ADC and the Tmax. The perfusion, they used a Tmax greater than 2. For CT, they used this incredibly complex equation that incorporates mean transit time, cerebral blood flow, cerebral blood volume, and the NIH scale in the infarcted hemisphere and the contralateral hemisphere. Now, it doesn't get any better than this. These are really smart people who put this together. And they spent a lot of time figuring out what was the ideal parameter to determine infarct and penumbra. In our model, differentiating ischemic core from penumbra, baseline diffusion, perfusion, MR variables predicted ultimate tissue fate with 80% accuracy. Whoa! That means there's 20% inaccuracy. So in clinical trials where we put together hundreds or thousands of patients to get a 5 or 10% difference in control versus treatment group, the underlying standard that they were using to determine their study is 20% inaccurate. So is that real? Same authors. They did series of studies leading up to the MR rescue trial, other multi-parametric studies. And in that, with MR and CT, they determined the infarct core models had overall accuracies of 71 to 80% in identifying tissue fated to be infarcted despite reperfusion. In the MR rescue, they then go on to say, patients who were evaluated on CT tended to have larger predicted cores than those on MR. So not only do you have an underlying 20% difference in accuracy or inaccuracy, you also have a different infarct depending if you were evaluated with CT or MR. That's a fundamental problem of clinical trials. So how do we do better? How can we use our understanding of basic principles of brain perfusion to provide a more accurate assessment? When we only have two things. We have the contrast concentration in the arteries, the AIF, the contrast concentration in the tissue. How do we do better? The first thing we can do is use a local AIF, arterial input function, instead of a global arterial input function. A global value typically uses one AIF near the skull base. The problem is that's removed from the tissue that you're going to measure the concentration of the concentration within. It's several seconds away from the tissue. Delay, as we know, we've seen this several times now in this lecture, delay corrupts data. Local is better, closer to the tissue, less delay. So, you all know what this looks like. This comes from a very well-known workstation. We're measuring the AIF within the anterior cerebral artery. We determine the arterial curve, we determine the venous curve, and we determine from that we truncate the curve, and then we measure the CBF, CBV, etc. A better way of doing this is to measure lots of AIFs all through the brain. And we can see here, and this is on Sphere 2.3, Sphere 2.2 product, we can see all of these X's indicate areas in which we are measuring the arterial input function. So we don't have one arterial input function, we have dozens of arterial input function. And what that does is it gives us a more uniform view of what the true arterial input function is in the brain. We're measuring the AIF closer to the tissue. Does this make a difference? It makes a huge difference. This is the, by MR perfusion, the area of reduced perfusion using a single or global AIF. This is, same data, the area of decreased CBF using local AIF. And this is the diffusion imaging. Local AIF methods were found to reduce the amount of residual dispersion in the perfusion maps compared with the conventional global AIF. Local AIF methods better characterize the severity and extent of perfusion deficit. 2, we can use better mathematical algorithms. Ultimately, it all boils down to the deconvolution formula. The best are time insensitive because the delay has less of an effect on your results. The best single-value deconvolution methods are the time-insensitive ones, such as OSVD, or oscillating single-value deconvolution. And we can see in this graph that the more time-insensitive SVD algorithms bring you closer to the true mean, to the true value, than the other the SSVD or other single-value deconvolutions. So a better deconvolution algorithm gives you better accuracy. Perfusion algorithms, like deconvolution, are dependent on the measured imaging information, and that introduces uncertainty because of noise. And as a result, the curve that you receive is variable because the noise introduces error. So what we see here is the true value for the residue function, and this is in the blue curve, the measured value using single-value deconvolution. And we can see it approximates the curve, but it bounces all around it due to noise. Can we do better? There are different algorithms. There are different mathematical constructs to do the same thing. So let's talk about Bayesian. Bayes' theorem is the maximum likelihood theorems, can be applied to brain perfusion if you use simplifying models. It's a probabilistic model that's based on assumptions from prior knowledge of flow, and it incorporates models of the microvascular hemodynamics. What does Bayesian algorithm do for us? It gives us a better correlation with true values than traditional SVD. It has a greater accuracy at the extremes of measurement, which is exactly when we want it. High flow in a tumor, low flow in an infarct. It has greater accuracy with the bane of our existence as neuroradiologists, noise and low signal-to-noise ratio. And it is better differentiates normal and pathological. So, same graph, except now we're going to look at the same data with Bayesian algorithms. And what we see is that the Bayesian in the red very closely correlates the true value. Because it's less sensitive to noise, it tends to bounce around the true value less. It is a more inherently accurate method. When you introduce Bayesian, it allows you to introduce new indices. Bayesian allows you to determine accurately the arterial tissue delay. That is the time difference between the arrival of the arterial input function and the tissue concentration curve. It's a true measure of circulation delay, and it is not corrupted by the same factors that influence Tmax, such as signal-to-noise ratio. It is a more accurate measurement of the adequacy of collateral flow. Furthermore, not only can you use a new indice, the indices that you were using, such as CBF, become more accurate. Bayesian algorithms have only been FDA approved and clinically available for about 3 or 4 months now. So there is limited data on Bayesian algorithms. And Dr. Naila afterwards is going to present us clinical cases so we can see exactly what it does for us. But there are a few studies out there. And the first is that MR perfusion with an arterial tissue delay of greater than 6 seconds in patients with MCA M1 occlusions has a significant correlation with the angiocollateral flow, which we saw during thrombolysis, as well as a significant correlation with cerebral blood flow. Secondly, a 2-parameter index, multiparametric, arterial tissue delay of greater than 27, ATD of greater than 6 seconds, that gives you a volume of greater than 27 cc's, plus the DWI, is the best predictor of non-recanalization for patients with MCA M1 occlusion. So, in summary, clinical application of perfusion imaging has suffered from inaccuracies and inconsistencies in modeling, software, and acquisition. Newer models and algorithms may be superior to traditional methods and compare favorably with the gold standard MR diffusion imaging. CBF and parametric indices will be the measure of infarct. CBV is not. And lastly, mean transit time and Tmax, a commonly utilized estimate of infarct, are problematic, and arterial tissue delay may be a more accurate indice to be used instead. Thank you very much.
Yeah, thanks a lot for that excellent talk. That gives us the insights into the mechanisms of perfusion as well as the problems that we suffer while evaluating the data. And in respect of time, we move directly forward to the next speaker, Kambis Nail, will give us now insights into the clinical translation of these new post-processing algorithms.
Thank you. Thank you for your introduction. Thank you everyone for being here. I'd like also to thank Olea Medical for inviting me to this to give this presentation. Since Adam gave us a really nice background about the basics of MR perfusion and different post-processing technique, I'm going to transition to a slightly different focus and show how we can do reduce the dose MR DSC perfusion and how we can adapt this into our clinical practice. So over the next 20 minutes, we're going to talk about how to reduce the contrast dose for our DSC perfusion. I'll show you the feasibility study that we have on this topic, and then go over the potential clinical applications, and I'll show you some cases. So I think most of us in this room are using brain DSC perfusion to some degree for stroke imaging, brain tumor imaging, or as a problem solver in our daily practice. The current standard dose of DSC perfusion is about 0.1 millimole per kilogram gadolinium. So why use less gadolinium for DSC? I think there are several incentives, but the main one, at least for our practice, is the increased demand for use of combined multi-enhanced sequences in routine diagnostic MR applications. For example, for stroke imaging, we like to use a combined contrast-enhanced MRA and DSC perfusion. For brain tumor imaging, we like to combine DCE and DSC perfusion. And therefore, you have really two options. You either give these patients 2 doses of contrast, or you split the standard dose of 0.1 and perform both of these sequences in your imaging protocol. Direct relationship between the risk of NSF with contrast dose and reduction in the cost, obviously, would be other reasons to do that. So what are the challenges in contrast dose? I think Adam really described this in very nice detail, but I think the main challenge is really the limitation imposed by signal-to-noise ratio. As we all know, most of the post-processing packages available to us use some sort of deconvolution, and which is an ill-posed problem where small changes in your data can dramatically influence your residual function. And therefore, reducing the contrast dose, obviously, would result in low SNR, can further accentuate this limitation. So since the introduction of Bayesian probabilistic method, which is inherently less sensitive, as Adam discussed in his talk, we thought that to perform a feasibility study to basically evaluate its potential clinical application. So what we did, basically, I'm just going to go through, I presented this paper yesterday. If you're interested in more detailed presentation, number was 332. But I'm just going to point out a few important things in our result. So we basically evaluated 20 patients. We scanned them on 3T magnetic field. We used 20 coil elements for signal reception. We used a standard DSC perfusion sequence, a gradient EPI with temporal resolution of 1.5 seconds. And this is our image acquisition scheme. We basically, after doing non-contrast images, we did our half-dose MR perfusion using 0.05 millimole per kilogram DSC perfusion. Then we did our T2, T1 weighted images for about 8 minutes, and then we finished with a full-dose DSC perfusion using 0.1 millimole per kilogram. We used multi-hands, and the injection rate was 5 cc per second. We processed the images using Olea software. We did both CSVD deconvolution and Bayesian probabilistic method post-processing. We co-registered CBF, CBV, and MPT maps, and we performed quantitative analysis in both gray matter and white matter. Here I'm showing you the noise distribution and SNR in a patient who was scanned with half-dose perfusion, DSC perfusion. And then 8 minutes later, again, same patient was scanned with full-dose perfusion. And you can clearly see that the noise, increased noise and low SNR is a real problem. You can see this heterogeneity over the field of view, this accentuation of the parallel acquisition artifact here, as opposed to full-dose perfusion, you really don't see it. So we look at the SNR values, and we find about 36% lower SNR in our half-dose perfusion compared to full dose, not surprisingly. And this was in agreement with prior numerical simulation. These are the color-coded maps of MTT, CBF, CBV in a patient who was scanned with half-dose, shown on top row, and full-dose DSC perfusion on the bottom. And you can see there are some heterogeneity across the field of view in MTT maps, in CBV maps, that you really don't see them on full-dose perfusion. Again, on the other side, clearly the effect of noise and SNR penalty. And this patient also had a small right frontal convexity meningioma, which had increased CBV, and you can barely see it on half-dose perfusion study when processed with deconvolution technique. The same data set, same slice position, processed with Bayesian, and you can see that the maps are more uniform. The heterogeneity that you notice here is not really there. They're more uniform, the comparison between half-dose and full dose. And the meningioma is seen on both, although less intensely seen on half-dose perfusion scan. So let's look at some numbers here. We basically did a quantitative analysis in the gray matter. We put a region of interest in the pre-central gyrus, and these are the numbers that I have. So on top, I'm showing you the Blant-Altman plots, and at the bottom, you're looking at the bivariate scattergrams with 95% confidence interval lines. You can see that there is significantly smaller mean differences between the full dose and half dose cerebral blood flow values when processed with Bayesian compared to deconvolution, and also better correlation between the two in comparison to deconvolution method. If you look at the cerebral blood volume values, really similar findings. So you can see smaller mean differences, the narrower range between the values as opposed to deconvolution technique, and again, better correlation compared to deconvolution. Similar finding really in MTT, smaller mean differences, better correlation again. And then we did the same analysis in white matter. We're putting a region of interest in the centrum semio-valley. And as you expected, white matter low-dose perfusion can be even more problematic due to low perfusion value. And this was reflected in our result. You can see clearly we have smaller mean differences when we're looking at the full dose and half dose CBF values in white matter compared to deconvolution technique when processed with Bayesian. And again, better correlation between the two. Similar finding for CBV. I'm going to speed through this since we're running a little late. And again, the mean transit time was probably the most affected parameter in our data. You can see that there was almost no correlation when we're looking at white matter mean transient time in half-dose between half-dose and full-dose perfusion, as opposed to fairly decent correlation on Bayesian technique. This was a 40-year-old man with multiple sclerosis. This cortical-based non-enhancing lesion. Question was low-grade glioma versus tumor-active MS. He was scanned with perfusion. We did both half-dose and full-dose, and you can see these are the maps processed with CSVD. You can appreciate this heterogeneity that you can see in half-dose perfusion. Again, some heterogeneity on the cerebral blood volume maps when you compare to full-dose perfusion. But if you look at the Bayesian technique, you can see that the maps are more uniform. Again, these are the same data set, and you really don't see those heterogeneity that you would see on CSVD. Let's look at some numbers. We put a region of interest, and you can see that there was overestimation of MTT by a factor of 2 in this lesion in half-dose group when processed with deconvolution, as opposed to closer range of values when processed with Bayesian. Underestimation of CBV by a factor of 2 in this lesion, again, when processed with deconvolution, compared to relatively close numbers when you do post-processing with Bayesian. So I'm going to talk about the clinical applications for which we're using this low-dose DSC perfusion. We really use it at this point for two main clinical protocols, one for stroke imaging, the other one for brain tumor imaging. So at our institution, we have a 6-minute MRI stroke protocol. I will present this talk tomorrow morning. Presentation number is 716. If you're interested, please welcome join us. Basically, we do a combination of EPI and parallel acquisition to accelerate the acquisition time. We do DWI, EPI flare, EPI GRE. We do a split dose contrast enhanced MRA followed by DSC perfusion, and therefore this DSC perfusion is done with half dose contrast at the end of the examination. I'm going to show you one case that I'm hoping that can highlight a few points. This was a 61-year-old woman presented with right-sided weakness and aphasia. She was scanned 90 minutes after onset of presentation with the baseline NIH stroke scale of 17. These are images from our 6-minute stroke protocol. You can see that she clearly had a left MCA infarction with involvement of basal ganglia. This was a hyperacute stroke, no flare hyperintensity, no hemorrhage, large perfusion deficit, and a carotid ICA occlusion on this MRA. These are near isotropic voxels. You can actually do multiplanar reformation, and you can clearly see that this carotid is occluded, the absence of MCA branches, and retrograde filling of the A1 from the contralateral side. She underwent endovascular recanalization, which unfortunately failed, and 6 hours later, she had this follow-up examination. You can see that the infarction is relatively stable. It didn't really grow that much, but unfortunately, she developed hemorrhage in the basal ganglia with intraventricular extension that you can see on GRE images. Now you have flare hyperintensity in the region of infarction, as you would expect to see in a patient who is out 6-7 hours from the onset of presentation. So I'm showing you this slide because this is the best I could do to show a side-by-side half-dose, full-dose perfusion in an acute stroke patient. For ethical reason and IRB issues, we can't really do or duplicate this in a real time or in a real patient, but at the same time. So the first scan was done using our 6-minute stroke protocol. These are half-dose perfusion images. The second scan, we didn't do contrast-enhanced MRA, and therefore these perfusion images were acquired with full-dose perfusion. And I'm showing you the time to pick maps. I don't personally use TTP in our clinical practice, but I'm showing you to highlight the point that Adam made in his presentation, that TTP is a simple perfusion parameter for which you don't really need any fancy post-processing, such as deconvolution. These are basically derived directly from the concentration time curves. And you can see if you don't need to do post-processing, such as deconvolution, the half-dose images will give you a decent image quality compared to full-dose perfusion. But the problem really happens when you need to look at the numbers, when you need to do quantitative analysis, and such as MTT, for example. If you like to look at MTT, you can see these are the deconvoluted derived MTT maps. These are heterogeneous in appearance, and we have a hard time delineating the perfusion abnormality. Contrast this with Bayesian derived MTT. You can see a better background suppression, less noisy, and better delineation of this perfusion abnormality. And again, as Adam mentioned in his presentation, your Tmax or time to maximum maps are affected by SNR and MTT. So if you're doing a low-dose perfusion study, if you have low SNR and bad MTT, you're going to anticipate that you're going to have a bad Tmax. And this is reflected here, really. If you compare that to Bayesian-derived arterial tissue delay, which is the closest we have to Tmax derived from deconvolution, you can see that you see a lot of red spots here that are indicative of delayed perfusion more than 6 seconds. You see a lot less red spots on Bayesian derived, indicative that this was actually overestimation of the values due to noise. And this was reflected in our follow-up study that this patient infarction didn't really grow. Finally, I'd like to just discuss this very briefly about the second imaging MR protocol for which we use half-dose perfusion. We use a combined DCE, DSC, specifically for evaluation of brain tumors and post-treatment changes in our brain tumor patients. We like to take advantage of the complementary role of DCE, especially where susceptibility artifact can be a limiting factor, and also for quantitative assessment of blood-brain barrier. Again, this was presented yesterday. If you're interested, you can refer to this presentation, 405. But I'm going to show you this example to highlight the point that why we like to use this combined DCE-DSC protocol. So this was a 54-year-old man with history of high-grade glioma, status post-resection, and treated with radiation and temozolomide. 5 months after treatment, he started developing this enhancing lesion in the right inferior frontal lobe with the clinical question of radiation necrosis versus tumor recurrence. You can see these are co-registered maps. If you put a dry region of interest in this region, you can see that there is susceptibility artifact in this location affecting the quality of your RCBV values, which basically was non-diagnostic. If you look at the DCE, clearly you can see increased K-trans with a rapid vascular phase permeability, suggestive of tumor recurrence. This patient underwent another scan 3 months later. You can clearly see extensive infiltrative glioma. Now you have enough tumor away from plenum sphenoidale that you can also pick up the increased RCBV, and this was a pathology-proven glioma. So this is how we interpret our perfusion imaging for brain tumors. And again, that's what we adopted in our practice. Could be significantly different from what a lot of people use in this room. But if we're looking at radiation necrosis versus tumor recurrence, we start with RCBV. If the value ratio is more than 1.5 in the region of enhancement, we call that recurrence. If it's less than 1, that's radiation necrosis. If it's between 1 to 1.5, then we like to look at some comparison to see if we can see the time differences, the interval differences in RCBV ratios. And we also look at our DCE perfusion. If the K-trans is increased and we have rapid vascular phase permeability curve, that would be radiation necrosis. And if the K-trans is decreased and we have steady state permeability curve, that would be radiation necrosis. So I'm going to end with this case. This was a 59-year-old man with GBM diagnosed in September 2013. He was treated with gross solar resection, radiation, and temozolomide. 5 months later, he developed this nodular enhancement along the anterior margin of resection cavity, and this was grown on subsequent scan. The question was radiation necrosis versus tumor recurrence. He was enrolled in our combined DSC-DCE perfusion. Therefore, all the CBV maps that I'm showing you here are acquired with half-dose perfusion. So on the top, these are the RCBV values that are processed with Bayesian. On the bottom, these are the CBV value maps that are processed with deconvolution. And when you look at registered like 3 sequential DSC perfusion images, if you look at the Bayesian process images, you can see this progressive decline in RCBV values, with the latest RCBV being 0.08. That's the RCBV value compared to the contralateral side. And if you look at the convoluted CBV maps, you can also see this decline, progressive decline in RCBV, but not as steep, and with the latest being 1.3. So if you adopt this imaging interpretation table, looking at Bayesian, this patient would have radiation necrosis. Looking at CSVD drive map, this patient would be in the indeterminate category. And this was, in fact, a surgically proven radiation necrosis. So in conclusion, reduced contrast dose brain DSC perfusion is feasible using Bayesian probabilistic method with comparable quantitative result to full dose perfusion. Bayesian method is less sensitive to low SNR and can result in acceptable quantitative measurements of cerebral perfusion if you decide to use low dose contrast protocol. And with that, I thank you for your attention.
Yeah, thank you very much to both of the speakers. Because we have inherited already some delay from the previous session, and to stay on time for the whole day, we just discussed that we might offer you some discussion outside. So we would like to continue then with the next session. But a few last words. I think we have learned quite a bit in that session, how to perform. And first, how to prepare our perfusion protocols. We learned about the complexity of the model and how this complexity can influence our clinical decision, which was proven in some of the trials that were presented in the first presentation. We have learned about new post-processing algorithms and how they can make our perfusion data better and better to interpret in the clinical environment. And we have learned about possible clinical implications or indications also with a reduced dose protocol. And I would like to thank again both speakers for their excellent presentations. And I would like also to thank Olea Medical for the sponsoring of this event. Thank you very much.